with our panels. Can we open to our audience? Any question? Please raise your hand. And we have here one question. Please give mic.
Hello, thank you very much. It was a very interesting three talks. I just want to ask, usually patients with the mental illness and substance, and it's not just one substance, it's multiple substance, and the alcohol, and then the smoking. So, which of the lesser evil do we tackle first? That's number one. And number two is that I notice when I counsel my mental health patients, alcohol, maybe, they can reduce. Substance also, it depends on them. But usually if we touch about smoking, it's like, oh no doctor, tak boleh doctor, that itu tak boleh. The others, they are willing to reduce. So, yeah, thank you.
Thank you very much. I believe this question for Dr. Menho.
Sure. Thank you very much for the question. With regards to the part where you said about smoking and multiple different substances, which one do we target first, right? Actually, conventionally in mental health, we used to go for the substance that cause the most harm first. However, that's not in line with what the evidence shows. Evidence shows that you should target all together. So it's not targeting alcohol first and then tobacco later. It's not targeting, methamphetamine use disorder first, then the target to it. Actually, they said to integrate all substances for treatment together. And the reason that some of them find it more challenging to stop tobacco, of course, because of nicotine addiction. Okay? Nicotine has a very short half-life. Anything with a short half-life has a high dependency rate. So nicotine is among the most addictive substance that you can be on. But we do that at a sheer expectation of willpower. We tell them that you should stop, but we do not offer evidence-based therapies. Even in our practice, many times we tell them, you should stop this, and this. But we don't give them nicotine replacement therapy. We don't give them phenanyl. We don't give them glucophage. We just tell them that you should be stopping it. At best, we tell them you should buy nicotine replacement therapy outside. And it's so expensive. Our patients do not have that resources. So, integrating it together, having effective treatment. Because if you see, there is not much effective treatments for other mental use, substance use disorder. Like if you are talking about things like methamphetamine use, there's no medication. But in nicotine use disorder, we have medications, but we are underutilizing it. That's what makes them harder for them to be on.
But doctor, would it be like overwhelming for them? Like it's too overwhelming, like stop everything.
Yeah. So I grew up learning. I grew up with the same mate actually, and we until recently used to do that, tackle the most severe issue at hand. Even tobacco with other like depression or tobacco with schizophrenia, we used to just deal with schizophrenia or depression first. We don't even address tobacco at that point in time. But evidence does not show that. So now we are going more towards targeting all at once. So, but clinical practice might still be different because many of us are still governed by the myths that I've addressed earlier.
Also, just a bit of feedback. Like, because I practice in Seremban. So, Seremban Hospital, the psychiatric wards do not have any sort of NRP or anything like that in hand. Patients try to run out of the wards because they are stuck, they don't have their cigarettes. So banyak yang cuba escape. and then end up refer ke klinik kesihatan, and then have to wait for patients to be discharged after 1 month or 6 weeks. That sort of thing. So macam kesian lah kat patient.
Thank you very much, Doctor, for the feedback. And I totally echo because I used to practice in Seremban when I was a houseman in psychiatry. And we do see our patients struggling with that because we do not have that. And we see patients, cooperating with each other. So when patient A discharges, they come in and smuggle in cigarettes for the other patients later on. And they even have a place where they throw in cigarettes from the top of the hill into our ward. And I assume that it's still going on after I left houseman 12, 13 years ago, but thank you for the feedback. I will pass it over to my colleagues then.
I have one question about in the public health. So I just want to know if the policy that giving the power to the inspector kesihatan to find people who are smoking, how about the usual citizen who are going to stop smoking in like a kedai mama or whatever, and then when we are explaining to him in a nice way, and then he will be angry lah about that, and then it become fighting among the citizen, because the citizen don't have any power to find the people who are smoking in the restaurant lah. It is prohibited to smoking. So any policy of the government can do in giving the power to the citizen to do whatever lah, so that we will not be on the side of yang tak salah. And then one more question for is it right if we don't give any antipsychotic, because you say that smoking is reducing the antipsychotic effect, then we easy the patients. Okay, thank you.
Thank you very much for the question. It's very interesting. And I guess it's actually in the mindset, if we are able to get into all the citizens that smoking has got more harm than benefit, and if we are able to grow our younger generation to become the generasi bebas rokok, so that will change the scenario. So hopefully, when we are able to really ground our younger generation that smoking is not a norm. So we have to change the narrative. It is not normal to smoke. It is something which is that's very weird. So they have not seen smoke, they don't know cigarette, they don't know vape, they don't know e-cigarette. So if we are able to reach that stage, then probably there won't be any gaduh-gaduh dekat restaurant for you to get the other customer to stop smoking. But if they do not understand, if they don't have the willingness to also contribute to clean air, that's where issues happen. And it is not easy to have a policy where to allow all citizens to be able to find anybody. That won't be a very good way forward. Yeah. I guess the best way would be to denormalize smoking, to get the younger generations to understand that smoking is not a norm. It's there's more harm than good, and if we are able to achieve our smoke-free generation by 2040, or to have a smoke-free country by 2040, that will be a better way. Hope that answers your question.
The next one with regards to antipsychotic. No, the short answer is no. You can't take them off antipsychotic because if you're dealing with patients with schizophrenia, there is a hyperdopaminergic state in the mesolimbic pathway. However, there is a hypo, that means lower dopamine level in the mesocortical pathway. That's why I said it temporarily elevates mood, because in your mesocortical it's more mood, your concentration, attention. So it helps with that symptoms. But smoking does not help with your positive symptoms of schizophrenia like hallucination and delusions. So you still need antipsychotic to bring down the dopamine levels there. Number two, ECT. No, we cannot use ECT long term because just imagine I will have to call you in for giving current to you 3 times a week for the rest of your life. I don't think so anybody will be open to that. So ECT is a good modality for short-term treatment, but long-term we still need to rely on medication.
Hi, good afternoon. Dr. Samuel, I'm a GP from Seremban. I'm just curious about the, what do you call this, the government's perspective on setting up designated smoking areas. Because, for example, now it's fantastic that you don't smoke in malls and restaurants and hospitals. But I've seen in my own eyes, as soon as you step out the hospital gate, you will see PPKs, you will see medical officers having their cigarette. And they won't be in the mama anymore because the mama also don't lounge, they'll be standing beside the road and smoking. So what we call this, our neighbors, Singapore, we call these government offices and public places have designated smoking areas. I'm sure the government has thought of it. Is there any reason why they have not implemented it yet? One question. The second question is, as a GP, when I talk to my patients and what we call this, ask them to stop smoking, of course the first question is cannot. But when we go deeper, we ask them why you cannot smoking. It's fraction. It's the younger generation and it's the older generation. The older generation, they're like, oh, your doctor, it's the best thing for me in the morning. That's what I look forward to. Nothing better than my Nescafe and coffee and my cigarette. And then I go to the toilet, very nice. So, listen, actually I've gone to the stop smoking clinic, it's free in the KK in Seremban. They're like, yeah, but they don't, they call this, they give me they talk to me, they give me a date, they say I want to quit. And then what they call this, they give me some medication, some patches, but they do not address my other issues, doctor. So I was like, oh, so is there any way that we could approach this as a multidisciplinary problem for smoking? 1, 2. For the younger generation, I realize that there's a lot of mental health issues cropping up. They smoke because they're influenced by their peers, they want to look cool beside their friends. They call this, or more or less their anxiety, they have anxiety, or what they call this, they've got low self-esteem. This is the younger generation's problem. The older generation's problem is more physiological. So what I see the KK, when they address the smoking issue, the MO doesn't approach this as a multi-systemic issue, rather more they have a target, they go for the target, but most of the time, from what I'm seeing in my patients, you have that approach is not going to work. What is the solution or your comments to that?
Thank you very much for your question. That's very interesting. Your first question regarding designated or the designated smoking room or smoking area, right? So if it's based on WHO's FCDC document on protection people from exposure on secondhand tobacco smoke. If we actually have a designated room for smokers, it will not comply to the FCDC. So that's why our country they do not encourage this. Although we see in other countries they have designated areas, so for example in the airports. But if we want to comply 100% according to what FCDC requires in the convention, the framework convention for tobacco control, then there shouldn't be any areas for smokers. So we need to be 100% smoke-free environment so that we'll be able to achieve the P in the Empower. Right? Empower is a strategy from WHO. So P is on protect people from tobacco smoke, or now protect people from tobacco smoke plus the aerosol from your vape and e-cigarettes. 100% smoke-free environment requires no area to smoke. It needs to, we actually need, it's not an easy like an overnight thing where you can get your smokers to quit. It's actually it's very challenging. And I really like the suggestion that you said in end to have an integrated system rather than just focusing on target. Because having an integrated system where we to see the patient as a person who smokes, who has an issue, and then we need to have the clinicians to support, to provide the treatment. We also need to have a system where the person can be supported, not just at home or not just in the health system setting, but also in the environment. So if it's a person is in an environment which is smoke-free, there is no way that he or she, I shouldn't be biased here, he or she can start smoking. So it is very important to have a supporting system and also an integrated system together to help a person to quit or to stop smoking. So have I answered your question?
Yeah, I was just very curious why there was no designated smoking use. I personally think that's a fantastic idea to reduce second-hand smoke exposure. So for those who have trouble breathing, as you said, there are certain policies in place, so we have to abide that.
I definitely echo your view with regards to we cannot just address smoking just unilaterally. We need to see, like what Dr. Prof mentioned as well, in a multi-dimensional model. And that's why in psychiatry we use a framework called biological, psychological, social, spiritual, and lifestyle. We look at issues in all these categories and we try to address that holistically. And addressing just one, it will be indirectly not doing justice to the particular patient itself. Because if I was just going to address your smoking and not address your anxiety, or just address your smoking and not address some of your physical withdrawal symptoms, it will be unfair. Yeah, if we could work towards an integrated care, a multidisciplinary care, that would be the way forward. Thank you for the suggestion.
Thank you.
Do you have any more questions? Yes, thank you.
It's not a question regarding about doctor asking about designated place to smoke. Actually, like Dr. just now mentioned, in 2011, Melaka had Melaka Bebas Asal Rokok, which is represented in Bandar Hilir. But prior to that, after a few years later, the PTT, Pihak Berkuasa Tempatan, actually did have designated area for smoking due to a lot of complaints because of the tourists, those people visited at Bandar Hilir area will be in charges with our Inspector Kesihatan. So basically there is a designated area for smoking in Bandar Hilir Melaka, even though we are gazetted as Melaka Bebas Asal Rokok.
How about in Japan? Is it Japan policy about smoking?
Yes. Yeah, thank you for asking. Okay, I live in Tokyo actually, and for example, in Tokyo, you can see a sign that shows this area is prohibited to smoke, and if you smoke in this area, you have to pay fine in USD, $15. And also, the government prepared volunteers that tell people this area is prohibited from smoking. So that's what Japan is doing.
But sorry, but I've been to Tokyo. So
Oh,
it's
okay.
like the areas where, that I saw all
Yeah.
the like smokers go there, and there's a sign that says this is a smoking area. Yeah, so I have come across on the streets of Tokyo that you have designated smoking areas, right?
Yes, that's correct.
Yeah, yeah.
Also, now there's a regulation that the facilities have to show that this building has a smoking room, and this building is separates non-smokers from smokers. This is regulated, so our office also shows a sticker in front of our entrance. Yeah.
And sorry, so Mr. Yamanaka, I just want to ask you about that oscillation.
Oscillation, yeah.
Yeah, that oscillation method.
Yeah.
Just interested, which health facility in Malaysia is that available in? And how much is it actually?
Okay, for our most graph, our oscillation device is not available yet. Yeah, now we are trying to promote it. And actually yesterday I visited a respiratory institution in Malaysia, and that facility already has one oscillation device from Germany. And I talked with some clinical staff there, and it was used, but he said it's difficult to interpret the result from oscillation. That's one of the challenge about the oscillation, because spirometry is the gold standard for COPD diagnosis, but FOT has no gold standard so far. Yeah, there's many research about FOT, many researches, but there's no standard so far.
Sorry, just to echo the question, in terms of cost effectiveness, if you monitor a patient using spirometry and oscillometry, how would you compare the cost effectiveness?
Yeah, thank you for asking. Okay, oscillometry measures the respiratory resistance. Okay, it simply means the difficulty of breathing. So, for example, COPD patients in spirometry, FEV1 bar FVC is lower compared to the standard value. So in oscillometry, respiratory resistance is getting higher for COPD patients, because COPD patients' airway is narrow compared to the normal patients. So if we compare spirometry and oscillometry, FEV1 per FVC is lower and respiratory resistance is higher, then it's very helpful to confirm the diagnosis for COPD.
But the cost, if you compare between spirometry and oscillometry, the cost, the price of
The price.
Yeah.
Okay. Sorry, I'm not sure about the cost in Malaysia here, but in Japan, actually, both spirometry and oscillometry can be covered by the public insurance. Yeah. So actually, spirometry is cheaper than the oscillometry, but since it's covered by the insurance, oscillometry is not so expensive to perform. So that's why FOT is now very popular in Japan. But I think in Malaysia, FOT is not so popular and not covered by the insurance. So I think oscillometry is very expensive here in Malaysia so far.
I think we have a very limited time, so I think I may need to take only one question. I think from there, just last question. So someone.
My question has been asked regarding the oscillometer.
Already been asked. Okay. So I think we have to conclude now. So before we conclude the session, may I invite each panelist to share one final message to healthcare professionals in strengthening smoking cessation in Malaysia or globally. Yeah.
I mean, my final message is don't forget the vulnerable group. Include them in your policy, include them in your research, include them with providing evidence-based care. That's my final
My message would be to make smoking a would be normalize smoking so that we will be able to reduce the second-hand smoke effect.
My final message is if you have symptoms like a cough or sputum, please don't hesitate to go to the clinics, and please have spirometry test and detect your COPD as soon as possible.
So let's conclude our session today. So thank